So next up, I am thrilled to introduce Denise Adams to the EHE community. As we know, EHE affects children as well as adults. So we are very thankful to Dr. Adams from Children's Hospital of Philadelphia to discuss pediatric EHE. Children are not little adults, or are they? So everyone, please welcome Dr. Adams.
Thank you very much. It's really a pleasure being invited amongst all you wonderful, mostly adult people for EHE, and it's just important for us to collaborate. So I'm a pediatric oncologist, and we're taught in pediatrics that kids are not little adults. And so the question is, are they little adults? Is their EHE the same as it is in adults? You know, we know that there are certain sarcomas and there are certain leukemias that even in young adults, so even in people who are in their 30s, are more like a pediatric cancer than they are like an adult cancer. And our trials, a lot of our trials will go to the age of 32. So it's just something to think about and to ponder. So I have some, I have some disclosures. I am would you mind advancing the slides? Because it's just sticking a little bit. But going back to the disclosures, I am a consultant for Novartis, and I'm also a consultant for Ventura. And a lot of the drugs that I use, particularly in pediatrics, are all not FDA approved. So if we could go to the next slide. So my outline is I'm going to explain to you a little bit about how I became a pediatric oncologist that specializes really in vascular disease. And we call ourselves vascular anomalists. So we take care of tumors and we also take care of malformations. And I think it's really important that I got into this field because of what I call the power of one. So it was one patient that really changed my mission to help children and adults with vascular anomalies. I'm going to talk a little bit about genotype-phenotype discoveries that we had in the field of vascular anomalies, which is really important in general in oncology, and also talk about a study that a wonderful medical student did with me when I was at Boston Children's Hospital, where we looked at about 24 pediatric patients with EHE. So if we go to the next slide, please. So just going back to what I do, I take care of vascular anomalies, and vascular anomalies are broken down into tumors and malformations. Tumors are things that are growing. Tumors can be benign in vascular anomalies, but they also can be malignant, like EHE, like something called caposiform hemangioendothelioma, and also like angiosarcoma. And malformations are problems with the vasculature that have problems with growth functioning, but are not considered tumors because it's not just one cell that's growing out of control. So if we go to the next slide, please. So these are tumors. These are vascular anomaly tumors in children, and you can see there's a lot of heterogeneity amongst them. On the top, the two patients on the left side and the right side are all benign lesions, hemangiomas. The middle patient is a neonatal angiosarcoma. The patient on the bottom on the left is a patient that has an intermediate risk tumor called a caposiform hemangioendothelioma. The middle is a congenital hemangioma, and the other patient with the liver lesions is a patient that has diffuse infantile hemangiomas that actually progressed. One of them progressed to be an angiosarcoma. So if you go to the next slide. So a lot of heterogeneity. So when I started this 20 years ago as a pediatric oncologist taking care of these patients, this is what I talked about when we talked about what the medical treatment options were. So if you go to the next slide, please. The treatment options were what I called the chicken soup of medical management. So anyone that had a tumor or an aggressive malformation was given any agent that was proven in one or two patients to be anti-angiogenic and to possibly work. There were no studies. There was no preclinical data for any of these patients, even the tumors. And it was really distressing to me. So if you go to the next slide. So I've been at the three major pediatric centers. So I started at Cincinnati Children's, and then I went to Boston Children's, and they're the people who taught me all about vascular anomalies when I was training. And then I came to Children's Hospital of Philadelphia. So when I was at Cincinnati, we had protocols for the different types of malformations and also for the different types of tumors that we were taking care of. We had a big retreat for our center, for our Vascular Anomaly Center, and we decided that we were going to have specific ways that we were going to treat people with not only tumors, but also with malformations. So this was a patient, and this is my power of one, how this patient made a difference. So you see on the right is the Pic3ca Pathway. I was working when I was at Cincinnati. I'm a clinical researcher, but I was working with some basic scientists in neonatology and also in nephrology on this pathway, because we knew that P10 patients could get vascular tumors and malformations. And we also knew that tuberous sclerosis patients could get vascular malformations, and patients with other germline mutations could also have vascular problems. So our hypothesis was that this pathway might be important for vascular tumors and also vascular malformations. The same time that we were exploring this hypothesis, a patient came in, and I'm sorry for the awful picture, but this is a patient that has a tumor. This patient has a caposiform hemangioendothelioma. So another type of hemangioendothelioma that is in the WHO an intermediate risk malignancy, who had low platelets and low fibrinogen, who underwent our systemic approach to taking care of these patients, but our approach was failing. So started with chemotherapy, with vincristine and steroids, added Cytoxan, added Amicar on. We kept having tumor boards for how we were going to treat her. And then we added Avastin, and each time we would get a response, but then her disease would get worse, including something called her coagulopathy, which is called Kasabach-Merritt, and also the size of her tumor. And so we decided that she was at the point where we were thinking of palliative care, and we wanted her to get out of the hospital because she was there from the time that she was 2 months old, and she, in the lower picture, was about 9 months of age. And so we decided, if you click one more time, that we were going to use Seromas to see if this would treat her. So we didn't need an IND because Seromas is being used Seromas is an mTOR inhibitor. It was being used for tuberous sclerosis patients. It was being used for pediatric neurofibromatosis patients. So we actually talked to the IRB, we wrote up a protocol, and we used it on this patient. And if you go to the next slide, and this is what happened. So over a period of 18 months and more, her disease, the size of the tumor got improved. But the most significant thing that was in an 8-week period of time, what would have caused her demise, which was the coagulopathy, improved. Her platelet count went from 10,000 to 30,000, then normalized at 8 weeks. And also her fibrinogen normalized as well. So if you go to the next slide. So we got together as a team, and we decided that if we were going to treat more patients, because these patients, again, remember my kitchen soup picture, didn't have really any options, that we were thinking about and doing it in a trial type of a fashion. So we got together and we wrote a study, and we were incredibly fortunate to have it approved by and funded by the FDA Orphan Drug Disease. They have trials that are out there. And we also started at Cincinnati, but then we added Boston as a site. We looked at efficacy and safety and also some biomarkers. And we enrolled 60 patients, not just with KHE. We enrolled 60 very complicated patients with a lymphatic component, because that's where the research was with mTOR inhibition. And this is what happened. If you go to the next slide. So we didn't think that anyone would have a complete response. We know that even though KHE is a tumor, there's a lot of, again, heterogeneity, i.e. you're seeing very similarities between EHE. We knew that some patients, if we did imaging later on after their symptoms had improved, they always had active tumor that was still there. we knew that some of these patients actually had some recurrence of symptoms, not the coagulopathy when they went through puberty. So we weren't expecting anyone to have a complete response, but we were hoping, our hypothesis was that the majority of people would have a partial response. And 85% of patients at the end of 12 courses, so a year of therapy, had a partial response. Several of the patients had progressive disease, so 15%, but remember, we had a very heterogeneous, it wasn't just for KHE patients, because those are incredibly rare. It was for all tumor and lymphatic anomaly patients that were complicated. So if you go to the next slide. Just quickly going to show you some pictures of before and after. So this is a patient with a KHE lesion before and after on sirolimus, and you can see the response. And if you go to the next slide. This is a skin, so these patients can have significant skin issues, so before and after. And if you go to the next slide, this will show you a complicated lymphatic anomaly, who you can see what this patient, the only options that they had were surgical procedures. So at initiation, and you see at 15 months that even though this child required a trach, surgery is much better at 15 months than it is if you were to attempt surgery at the initiation. And if you go to the next slide. So that is how in the field of vascular anomalies, we really started with one patient with one hypothesis. We tried to prove it with a formal study, but then we truly realized that sirolimus was not enough. And if you go to the next slide, this is where we are today in the field of vascular anomalies. So our hypothesis that this pathway was involved became true. So all on the outside of this circle are all our disease phenotypes. And the inside is where there's mostly somatic mutations of Pic3ca, some RASopathies, some somatic mutations of the Pic3ca Pathway, and how we now are able to use phenotype and genotype correlation to help with our patients. So if you go to the next slide. So I put that in as an introduction because the same thing happened to me with patient stories of EHE. So I had two patients. One was a 2-year-old that presented to a cough, went to a pediatrician on several occasions, several rounds of antibiotics, and finally had a chest x-ray that showed pulmonary lesions. And this patient had pulmonary lesions, had liver lesions, and wound up, unfortunately, having EHE, getting chemotherapy that was angiosarcoma-like therapy, but not doing well because this patient progressed to pulmonary failure and died. Another patient that I had that really was powerful to me was a 21-year-old patient with a history of hemochromatosis who presented with liver and abdominal pain, was seen by an adult oncologist, was found to have liver lesions that were positive for EHE, was set to go to transplant, and at the time of transplant was shown to have very diffuse mesenteric disease, and then was sent to me to see if I had any medical management for her. So if you go to the next slide. So that, again, the power of one, the power of these patients made me really become engaged in patients with EHE, and particularly pediatric patients that had EHE. And so when I was at Boston, we had an incredible registry. We had a lot of patients who came to us, but also a lot of patients who came to our conference who we did consultation on. And so I had a wonderful medical student, her name is Ellie Cornover, who eventually published this data, where we actually looked at 24 pediatric patients. We went up to the age of 26. We had an approved IRB study, though it was retrospective. We made sure that these patients had enough clinical information that we really could get data. And in our IRB, we were able to survey these patients and call them back again to talk to them about their present disease status. So if you go to the next slide. So we had 12 males and 12 females. The mean age of presentation was 13.8 years. EHE was the initial diagnosis in only 50% of those patients. So a lot of them had either other pulmonary issues, or they had other orthopedic issues. The mean time to EHE diagnosis was almost a year, so 10.3 months. 79% of them had multi-organ disease. This might have been skewed because we were a referral center, so we might have only gotten the more severe cases. The most common sites of disease were the lung, and that being multifocal, the liver, and then the bone. And the most common presentation was lung plus liver. Go to the next slide, please. Our presenting symptoms, so going back to sort of what are the patients going through, in 54% of patients we saw pain. They were incidentally picked up in 17, and 29 had a palpable mass, mostly with soft tissue disease. Again, this might have been biased because we were a referral institution and might have seen only the most serious of patients. If you go to the next slide. So I'm going to pass through this because you all know what EHE looks like, and you also know about CAMTA1. Interestingly, we really only had CAMTA1 positivity in one patient, and less than 50% had a molecular diagnosis. But all of these patients, the pathology was re-reviewed by our pathologist who had an expertise in solid tumor pathology. You go to the next slide. Imaging was classical, so these are two pictures, and we know this imaging, multifocal lung lesions and also sort of liver lesions, the lollipop sign, which was talked about before. And if you go to the next slide. So treatment and long-term outcomes. So 8 of 14 patients were initially managed with observation and or surgical procedures. About half of them actually progressed. There was one complete response was observed after surgical resection in an isolated EHE isolated to the liver. The mean time to progression was 18.4 months, and the average time to follow up from diagnosis was 4.6 years. Go to the next slide. And you see, these are the combinations of the types of therapy that were being used. So if you see Seromas was used in 8 patients, again, we were probably skewed much later on in the courses when people were coming to us because we were very comfortable with the use of Seromas. But you see there's many other agents that were used. We talked about bevacizumab. Interesting, you see that the partial response and the length of partial response for some of these, like the sirolimus. Go to the next slide. So again, overall survival in a very small percentage of patients. And some people, we didn't have the information to have them available for this analysis. So 1 year was 100%, 2 years 86%. 5 years, 73%. During this study, 5 patients died, 4 from their disease and 1 from an unknown cause. Go to the next slide, please. So what were our observations? So multi-organ disease was present in 79% of our pediatric patients compared to a lower percent in what some of the adult literature is saying. Again, this could be skewed because we were a referral institution. The mean time to progression was 1.5 years, sort of shorter than the 4.8 years that's out there again in the adult literature. There is some suggestion of whether, observation should be, we talk about observation in the adult world. My sort of question is do pediatric patients sort of abide by these same rules? Over half of our patients initially were initially followed with serial imaging and or local surgery, went on to progress. We know sort of why we're using the anti-angiogenic agents that we are using. It's very interesting that some of them, like pazopanib, even though it was one patient, had a really long time, 4 years without progressing. And we also had some interesting observations with sirolimus, though the numbers are very small. So if you go to the next slide. So our conclusion is that, again, as we're saying for adults, there's a lot of heterogeneity in the clinical presentation of pediatric patients. we have to question, are pediatric patients different than adult patients, or is it that we were just seeing the high risk patients at our institution? With saying that though, because pediatric EHE is so rare, a lot of pediatric EHE cases are referred to the Boston group or to other pediatric groups that are familiar with taking care of EHE. So I do think that we're seeing the great majority of pediatric patients that are diagnosed with EHE. Our problem is this is a retrospective study, and it was a single cohort. I think it's really important for us to have long-term prospective studies, to have registries. I think it's important for us as well to be part of these adult new developmental therapeutics. That it was great that it was 15 and older for the Mechanist. It's too bad that we didn't have any people that were enrolled in that. But as we move forward with other studies, the FDA is even approving some therapies that go down to a pediatric age of 12 and above. So the next slide. So I just wanted to say that we do have a consortium now where we are looking at all of vascular anomalies, and there's 16 sites in the United States that's involved in this consortium. And if you go to the next slide, I want to really thank everybody for giving me an opportunity to talk about this small subset of patients. And I want to especially thank the patients and the families that we have worked with through this and their diagnosis. I think one of the big issues for pediatric patients as well is how long do you stay on treatment? So this has been an issue for all of us. And I think it's a little different, when you're dealing with a patient that's a lot younger than some of the older patients. And I want to thank our grant support and the other patient support groups. Thank you.
All right. So keeping in mind that you gave the disclaimer that the differences you're seeing with the multi-organ numbers being higher may be an artifact of the way patients are being sent to you. Is there anything that's been studied on the molecular side that would suggest there is a difference in the biology that might also explain that?
No, I mean, there was recently a report that came out from Ohio State looking at the other molecular, somatic mutations. And I know Brian is doing that as well. And I think when we were on a recent EHE call, I asked him if there was any differences amongst pediatric patients. The pediatric patients were not talked about on that paper, so I don't think that there were any, but I think that's important for us to keep investigating. I know for some of the other tumors, like the KHE patients that we're taking care of, there appear to be some other somatic mutations that are winding up being important for our risk strategy, our risk categorization. And then just going back to that, I mean, yes, I do think we're probably a little skewed, but again, I think this diagnosis is so uncommon in the pediatric population that I think the major pediatric sites really are sending those patients to referral centers, even if it's a early stage or non-symptomatic tumor. I think it would be really important for us to have a registry that has these patients included.
And then with your own practice or your group, do you use therapies other than Seromas with pediatric patients?
So we use Mechanist all the time for the other things that we're taking care of that have, that we have phenotype genotype correlation. So we are very familiar with that and would not be afraid to use that. If a patient had come to me that fit the criteria for that study, I probably would have used it. I think we, in general, the pediatric group of oncologists are a bit more hesitant about waiting and seeing, particularly if people have lung disease and liver disease, and if people are symptomatic. So I think our first drug that we go to is Seromas.
Got it. Now, relating to whether pediatric patients are little adults. Sometimes the law sees them differently. Are there any differences in the regulatory regimes that give you less of a menu of options available to treat these patients than you would with adults, or do you have the same full menu of options available?
So we treat all the time in rare sarcomas kids with drugs that are not FDA approved. Most insurance companies will have a clause that patients are allowed to be on studies if they have a cancer. And so the fact that this is a cancer makes it much better off for us to be able to get sort of a single IND or even it approved by by their insurance company.
Got it. And does that apply to surgical interventions as well?
Yes, it takes time, just like everyone was really talking about. We do a lot of cryo and surgical interventions for other things related even to vascular anomalies, and we have not had any problems getting those approved, sometimes with a little work.
Got it. So, getting back to your main theme of our pediatric patients, little adults, and you identified some situations where they're not in your data. Is there anything else besides what you presented that answers that question one way or the other?
Well, I think that those 24 patients is too low of a number. And so I think it's really going to be helpful to have a registry specific for these younger patients. And to actually get together and really talk about what the data points are that we want to capture in that. I think what the people in the Netherlands is doing is absolutely wonderful. We work actually with groups there with the other part with the vascular anomalies. And so I think that would be important as well to have in that.
Excellent. We got one last question here. Going back to drug selection, any intention to use sirolimus in combination with other drugs? Are you looking at combinations?
So combination therapy is always trickier because, a lot of these, we have some information about sirolimus now, we have the Mechanism study. We always add more side effects when we do things in combination. So for us and for you all as well, I think preclinical data is really important. Do I think that for some patients we will need two agents? Absolutely. But I think it would be nice to have some preclinical data to support that.
Got it. Well, thank you so much for your time and for giving this unique perspective, and look forward to hearing from you more in the future.
Thank you.
All right. Well, thank you, Dr. Adams. And thank you so much for being a vascular anomalist, because we appreciate you so much. Anytime we have a new patient join the EHE support group, it is a sad day. There's not that many of us. So when somebody joins, we all know it and it's sad, but it is really sad when it's a parent of a child. So we are so very grateful for your dedication to looking at EHE and these rare tumors in children and giving 20 plus years to it. So thank you very, very much.